Hi, everybody. Today we're going to talk about the new FDA guidance on de novo, and it's a draft guidance. And when I say new, we're talking the end of September. Sorry. So September 29th, the FDA released a new guidance on de novos in its draft, but it explains how to electronically submit a de novo and what the sections of a de novo should be. And it's not a required um, format yet. It's actually got a very weird transition date they're proposing way out there in time. So let me go to the very end of this document for you. Well, I don't have it up on my screen here. Let me look 1 second. September 30th, 2025 is the date that the FDA is tentatively proposing as a transition date. This blew me away that this was this far out. So the FDA's current process for electronic submissions of de novos is to submit using an E-Star. And the E-Star is mandatory already for the 510K, and that was implemented as of October 1st of this year. So everybody has to submit electronically for 510K. So what I would have thought would have been the logical thing to do is to take your 510K guidance for electronic submissions and just change the words in there so it says de novo instead of 510K and be done with it. And it's technically not that easy because there's a background section in the background history between what you would do for an electronic submission of a 510K versus what they've done for electronic submissions of de novos is going to be a little bit different. And the sections are a little bit different. There are just a handful of sections that are slightly different between the two. For example, there's a section on risk mitigations and benefit risk. So that's different. When you're looking at classifications, that's going to be different because there's not an existing classification for the device. You have to make a recommendation to the FDA for a classification. And another section is they want you to, instead of doing a substantial equivalence comparison, they want you to compare it to existing alternate methods of treatment and procedures and devices that could be used out there. So those are the primary differences between the two submissions. But otherwise, everything's the same. So we would expect the background to be a little bit different. We would expect the sections to be a little bit different, but otherwise it should be the same. And on the surface, when I first looked at it, well, it looks like the same header. It has the same number of pages. It has 16 pages. It has all the same sections in the table of contents. So what's different? You go to the very end of the document and it says September 30th of 2025. I'm like, why do they need to wait till 2025 to make this official that you shall go this way when the 510K is today and you can use the same E-Star template for it? I don't know. Evidently, they think they need more time before they can finalize that, and it may be because the de novos are going through slower than they probably should be, and they may continue to tweak the de novo format and content, and they may not say we want to continue to receive it this way. We want to receive it a different way. But I think they're having good success with the de novo. The E-Star, and that went smoothly as a pilot. They made it mandatory October 1st. You switch over to the E-Star. So why wouldn't you do the same thing for the de novos? It doesn't make any sense to me. So if somebody out there knows why they said we're not going to do a submission that's mandatory in 2023 or 2024 for de novos and we're going to make it 2025, please let me know. I don't know why it would be pushed out so far. But maybe the plan is we're not going to finalize this electronic submissions guidance until late in 2024, maybe around September of 2024. And then we'll give them a 1-year transition like we did for the 510Ks. So that would be September or October 1st of 2025. And maybe that's the mandatory date, and that's why they're giving us so much time. And that, I guess that makes sense from a bureaucratic standpoint, but it doesn't make sense from a cost savings and running your business optimally. You just want to use the same format for everything. So our business isn't using any more e-copies for any submissions. We're only using e-stars, but here's this guidance that says do it this way, and I don't exactly understand why. But looking at the outline of this, the first section is an introduction. So almost identical between the two. They really did just swap 510K with de novo, and that's all the changes are. So that makes perfect sense to me. There is different history, background, like I said, different time points at which they said, okay, this is the format that we want you to use for this type of submission, and this is we want you to use e-copy. Now we want you to use an e-star. So they have different transition dates there. That makes sense to me. Um, the scope basically identical, just swap 510K with de novo. So that makes sense as well. That's making sense. We have terms. They define the e-copy, they define the e-submission, and they define the e-star. They have a couple other terms that they describe as well, but those are the primary terms they're focusing on in the terminology section. And then they get to the current electronic submission structure that they're using. So they explain that, and then they give the future plans and what is the transition timeline date. So that's basically the whole entire guidance. It's only 16 pages. Um, and so the big thing that you're going to get that's very useful in this draft guidance is it gives you a table. And in the table, I believe is I think it's in section 5. I'm going to double check here. So it's a table that begins on page 7. At the top of page 7, table 1, structure of the current eStar de novo electronic submission template. So that's probably the only really useful piece of the entire guidance for you. It's giving you all the different sections of the eStar that you're going to have in a de novo versus all the different sections you would have in a 510K. And so if you do a compare and merge in Adobe of the electronic submissions guidance for the 510K versus the electronic submissions guidance for the de novo, you can very quickly see what the differences are between the two types of submissions. And like I was saying, the key differences are here that when you're going to look at a de novo device, they want to know what alternative procedures or similar devices already exist on the market because they're going to try to make a benefit risk comparison. They want you to identify the benefits of your device, the risks of your device, in the mitigation measures. They ask you to create a table for that. That they actually have you put that in there, and they give you an example of the table. And they want you to create a justification for the type of classification you're recommending, either a class 1 or a class 2. If it's a class 3, it won't be a de novo. Other sections here, labeling is the same, reprocessing is the same, sterility is the same, shelf life is the same, biocompatibility is the same, software and firmware are the same, cybersecurity and interoperability are the same, electrical safety, EMC, all that's the same. Performance testing, it's very likely that you're going to have clinical data in a de novo. It's not different. That section is designed the same way, has the same kind of requirements for a 510K because there are 510Ks that have clinical, but it's far more likely you're going to use that clinical section for de novo. References are identical. Administrative documentation, you're not going to have a 510K summary for a de novo. So that there's a little checkbox. Are you going to choose a 510K statement or a 510K summary? That doesn't show up in a de novo submission. And it doesn't auto-populate a summary for you. So none of that would be appearing in your de novo. But they just have that as the administrative section. And then you have additional information response only after the FDA gives you deficiencies. That hasn't changed. It's the same as the 510K. So essentially, 80% of this is identical to a 510K in terms of structure, and there's only a few differences, but the FDA doesn't emphasize that anywhere in this guidance document. So it's not helpful in that way. And they're proposing a 2-year transition from the time that they wrote this, which doesn't make much sense. That it would be 2 years from now. But I guess from a bureaucratic standpoint, most people I would think would use the new eStar template, and most people that are doing de novos would be familiar with the 510K, so they would stick with what they know. They would do the eStar, and then they would switch over. They would just answer it differently for the sections that are applicable for de novo versus a 510K. So there's not a lot different between these guidance documents, but if I were going to if I were going to take the time to comment on this new draft guidance document, the comments I would have is I don't see why we need to wait a year. That would be number one, or 2 years. I would accelerate the transition for let's make it effective October 1st, 2024 instead of 2025. So that'd be number one on my list. Number two on my list, I think I would actually offer up templates that people could have as appendices to this document for the different things that are only in a de novo that don't appear in a 510K. I think that would be helpful to people. Maybe the better place to put that is in the de novo guidance, which is where they have some of that, but they still don't provide templates for it. So the only time they've actually provided this template for the de novo table, comparison table, and how you manage risks and mitigation measures and provide traceability, the only place that's actually provided is in the eStar. And they could provide a little bit more guidance on that, particularly how to provide that and how to insert it into your submission. So that would be helpful. And they could put it in this guidance or they could put it in the other de novo guidance, but that would be very helpful. I don't see anything that needs to change for submission type. Cover letter, they might provide some guidance on how you fill out the cover letter differently because there's a slightly different structure or slightly different information you give in a de novo because um, you don't have a regulatory classification of the device. You don't have a three-letter product code. Some of those things are they could give you a little guidance on. They don't give you that guidance. So I think that would be helpful on the cover letter to give a little extra guidance. The pre-submission part correspondences, that's no different. You're just going to say what previous conversations you've had with the FDA, like a 513G. That might be a really good thing to emphasize. They do mention it here, but that would be a really good thing to emphasize because a lot of de novo should have 513Gs. Consensus standards, no change there. Proposed indication for use, you're not comparing it with another device. You're not saying how it's the same. So that question doesn't come up. But that's going to be basically the same. Classification, they have provided some information and guidance in the eStar itself, but they don't provide any guidance on that in this template or this guidance, this draft guidance that they provided. The benefit risks, like that table I was talking about, that's where it would be really helpful. They're not doing that. They do reference another guidance document, factors to consider when making benefit risk determinations. That's more about writing the benefit risk determination rather than providing that table. Labeling, there's nothing new there. Reprocessing, nothing new. Sterility, shelf life, biocompatibility, software, cybersecurity, EMC. All those should be the same. I would like to see a few more links in the performance testing section. I think providing a little bit more references to guidance documents that are more likely to be used in a de novo about clinical studies would be really helpful, and maybe the financial disclosure form links would be really kind of helpful. So these are additions that they don't have to make, but they would really help. And then, as I said, some of the things in the administrative documentation are going to be different because you don't need a 510K summary, but I don't think they need to provide any more guidance there. So there's a few places where I wish they had provided more guidance. They could provide them in the de novo guidance, or they could provide them in this, but I think it would be really helpful. So in general, they've basically just taken your 510K e-submission guidance, modified it to de novo, but the changes that they made are kind of curious, particularly at the very end, having a 2-year transition, and they missed some opportunities to actually provide some helpful guidance in certain areas that I would have liked to have seen, but that was potentially outside of the scope of what the person was supposed to do that wrote this. So if you have any other comments or questions, or you notice something different in the two documents that I didn't notice, or you can think of a new addition that would be great to be adding to this, if somebody comes up with a really good idea for something to add to the de novo template or this draft guidance, then we could maybe even submit something to the FDA within the comment period, because I think we have another little over 30 days to make additional comments here on this particular one. and tell the FDA what we think about this. I don't think it's one of those 6-month ones. I think it's a 60-day. I should probably search for that day. Yep, 60 days. So let me know in the next 30 days what you think should be added here, and maybe we'll submit a comment to the FDA, giving feedback on here's some things that you might consider to improve this guidance. But I think definitely 2024, not 2025. Um, like I said, comments down below. Anything that you think ought to be added, any ideas that you have, any questions you have, we'll be happy to answer them, and maybe even have an idea for next week's video. See you next week. Bye bye.